Hi guys, Dr. Gillard here. It is Monday. It's the spring of 2021. It's week 9. We're almost there. One more week after this. Okay, we're starting the prostate today, so let's talk about the prostate. We'll do a little anatomy first, not crazy into it, but it's a shield-shaped gland. Its base, just like the patella, its base is superior and its apex is inferior. It's found only in males, of course, located within the lower portion of the pelvis. It has 3 surfaces, anterior, posterior, and lateral, which we'll look at. It's clinically quite important because it's susceptible for coming down with 3 pathologies, the most common of which is BPH, benign prostatic hyperplasia, and then prostate carcinoma is also a big problem with older men, and then chronic prostatitis. So these are all, you've heard of all of them, right? They're not super rare like Marfan syndrome. Here's an A to P, or this is a PA view, looking at the back of it. There's the prostate. These are the seminal vesicles here, which we'll show you more anatomy on those in a second. Here's the vas deferens, or the ductus deferens, where the sperm would be traveling. These are seminal vesicle juices go into here. There's the posterior prostate. Prosthetic urethra would be inside, and that's the membranous urethra right there. From a side view, we can see more plumbing here. There's the vas deferens, sperm would come out of there. There's the epididymis, kind of a storage tank. Ejaculation occurs, it just squeezes, and you get a kind of a peristaltic wave of mature sperm, hopefully, going up the tube. There's also an ampulla right here where they can be stored in as well. There's the seminal vesicles. Together, their 2 tubes meet together and dump into the prosthetic urethra. We'll look at that here in a second. Here's a nice coronal view where we can see inside the prostate, and sure enough, there is a tube, the urethra, going right through the center of the prostate. So there's a left lobe and right lobe of the prostate, and yeah, that's what it looks like. So can you imagine if this gets hypertrophic and pinches off the pipe? Yeah, that's going to be a problem, as we'll see. Here's an overhead view, or S to I view. And we can see the posterior lobe, or the left posterior lobe, or just called the left lobe and the right lobe. There's a little sulcus here. And here's the rectum, and you can put the pad of your finger right here, which we'll be doing actually next week. Actually this week we'll be doing, week 9. We'll be doing the prostate exam on models, of course. But yeah, so that's the posterior part. We can feel, with our finger, we can feel the left and the right lobe. And we'll get into it. Let's get into these zones of the prostate. So histopathologically, the prostate has 4 distinct zones. The ones that are super important to us are the peripheral zone, because that's the one we can palpate through the rectum, and the transitional zone. That's the one that surrounds the prosthetic urethra. Then we have the central zone and this anterior fibromuscular stroba. So PCAT is the mnemonic that I use for pet cat. Or PCAT, and that works out nicely for that. Transitional zone, let's talk about this first. Now we're going to have hot dog bun on a hot dog bun on a hot dog bun. So the hot dog is the prosthetic urethra. So the hot dog bun is the transitional zone. T, I think of a little kid, our little kids used to say, I have to go TT, I have to go TT. That means they had to go urinate. So TT to me means it's right around the urinary part of where the urine is. That's how I remember that. But yeah, it hot dog buns, or it wraps around the prosthetic urethra. Super clinically important, because if the cells hypertrophy, it crushes the prosthetic urethra most of the time, and that can cause dysuria, and that's trouble going to the bathroom. That's the urine won't come out. You have to physically push down to get the urine to come out. You can wreck your bladder like that after years of that. It makes up about 5% of the weight of the prostate gland. And there's a beautiful picture of the hot dog bun around the hot dog. There's the prosthetic urethra, and there's the transitional, or the TT zone. Toddlers say, I have to go TT, transition. And so it wraps around there. There's the ejaculatory ducts. There's the seminal vesicles. And there's the ampulla of the vas deferens, so that's another storage area for sperm. So ejaculation occurs, an orgasm occurs, all this stuff contracts, and these juices squirt out into the prostatic urethra, specifically at a place called the verumontanum, is where all these juices and the prostatic juices dump into here as well. Right? Why do we care about the transitional zone? Well, if you get BPH, benign prostatic hyperplasia, some call it benign prostatic hypertrophy, same thing. It can crush the prostatic urethra if the cells become too hyperplastic. So, and most of BPH tends to occur in the transitional zone. So dysuria is a common problem in people with prostate problems. It's not the only problem, though. BPH is not the only pathology in this zone. About 25% of prostate cancers arise in this transitional zone. So the question is, how do you tell the difference between prostate cancer and benign prostatic hyperplasia, where they both crush the prostatic urethra? It's very difficult, if not impossible. You have to get a sample, a histological sample, to tell. I hear some of you saying PSA, get a PSA level. It'll be elevated in prostate cancer. You're right. But it can also be elevated in BPH as well. So it's very tricky sometimes. If you do develop a cancer in this transitional zone, it's not super aggressive typically. So that's at least a good thing. And yeah, it's, as we just said, it's tough to tell apart from cancer because they can both crush the prostatic urethra. Got to get a biopsy to tell the two apart. Okay, now we got another hot dog bun. This is the central zone, which basically hot dogs the transitional zone. It's about 25% of the volume of the prostate. It's located posterior to the transitional zone and therefore posterior to the prostatic urethra. It rests at the verumontanum on the bottom again. What is this verumontanum? It's this little raised region right here. And you can see we got some major tubes. There's the opening of the ejaculatory ducts. So that's where the sperm comes through and the seminal vesicle juice comes squirting out into this tube. There's a prostatic utricle. What does that do? You guys remember that from anatomy? Basically nothing. It is thought, some anatomists and embryologists believe this is a remnant of a male vagina. So do males have vagina? Maybe. Maybe this prostatic utricle. And then we have all these openings here, prostatic urethra. And these little troughs are called the prostatic sinuses. And these glandular elements of the prostate inject prostatic juice into the mix here. Transitional zone is more resistant to cancer, so that's a good thing. Only 10% of carcinomas arise from this area. Still susceptible to tumor infiltrate, though. So it's not that primary tumors don't typically arise here, but cancerous tumors from the transitional zone can invade it and infiltrate into it. If tumors do arise from here, which isn't very often, but if they do, they're very, very aggressive and dangerous. Some people can be gone in 6 months. Peripheral zone, that's the big zone. About 70% of the glandular tissue comes from this zone. It is cup-shaped, and so it's a hot dog bun again. So we have a hot dog bun and a hot dog bun, 3 hot dog buns. This one hot dog buns the entire central zone and about half of the transitional zone. And it connects to the anterior fibromuscular stroma. Let's look at it. So the transitional zone, 1 hot dog bun, prostatic urethra is the hot dog. Central zone, hot dog buns, the transitional zone. And now this peripheral zone kind of hot dog buns the central zone. Right? This is the one that we can palpate, though. Here's another drawing of it. All right, this peripheral zone. I wanted to show you how it, see how it connects. This is the anterior part. There's no glands here, no prostatic juices are made here. You can see how it connects to it in the front. Said to occupy the posterior and lateral part of the glands, most susceptible to inflammation and cancer. Let me say that again. If you're going to get prostatitis, prostate cancer, chances are it's going to show up in the peripheral zone, which in a way is a good thing because it is the most palpable during a digital rectal exam, which is, sounds horrible. It's really no big deal. I just had my I've had a bunch of these. I get these every year, every other year. And your GP can do them, and they take, 5 seconds for prostate exam. Not 5 seconds, maybe 10 seconds, 15 seconds. They're nothing to be worried about. Could save your life. About 70% of all prostate cancer start in the in the peripheral zone of the prostate. How big does a tumor have to be before you could get lucky and palpate it? It has to be at least the size of a regular marble, which is 1 centimeter. You can palpate it. We'll practice that, as I said, later this week. What's the sensitivity and specificity? How accurate is this prostate exam and the digital rectal exam? Prostate exam is part of the digital rectal exam. So the sensitivity is 81%, and the specificity is 40%, which is horrible. So it's not the greatest. It has a terrible false positive rate. So if it's positive, you just need to check further with a biopsy, but don't be too alarmed because it has a terribly high false positive rate. It's probably a false positive. If it's negative, though, you can breathe a sigh of relief because the sensitivity is 81. So although it's, still not the greatest, but there's still a 20% chance you could have a prostate tumor. But that's just looking pure statistically. It's probably less than that. What do you do if you find a mass? Well, if you find a mass, because we're licensed to do prostate exams, you have to send the patient out to a urologist. They'll do a biopsy. You could order PSA levels. You could send them to usually the primary doc does this stuff, but you could do this if you wanted. You got to get a PSA level in a biopsy, though. In fact, PSAs should be taken on all men, regardless of their urinary problems or no urinary problems, once you reach 40 years of age. It is associated with a high Gleason score, but I used to go into that. We're not going to talk about that. That's a paper test you could take. And that's just beyond the scope of this class. The last zone, the anterior fibromuscular stroma zone, it's very thick. There's no glandular tissue here, so it doesn't make any prosthetic juice. It's composed of connective tissue, dense regular connective tissue to be exact. It has a lot of smooth muscle fiber in there as well, so it's able to contract quite forcefully during orgasm. It helps kind of squeeze the prosthetic juice out of the rest of the prostate. There's smooth muscle everywhere in the stroma of the prostate, so when you have an orgasm, the whole prostate contracts. Okay, now with our anatomy muscles strengthened, let's talk about benign prostatic hyperplasia, aka a benign prostatic hypertrophy. Oh, they both say I just noticed that. One's hypertrophy, one should be hyperplasia. BPH. It is the most common benign neoplasm in the human male, period. A neoplasm is an abnormal mass of tissue that's become hyperplastic or dysplastic. So neoplasm could be cancer, it may be malignant. It just means a mass of cells have went wild and caused a bump. The results from nodular hyperplasia, it results in what's called a nodular hyperplasia, mainly of the transitional zone tissue, the TT tissue, and it can crush the prostatic urethra. There's different types of tissues may be affected, may go crazy. So connective tissue may go crazy by itself, and you get fibroblasts running wild. Maybe the fibroblasts are normal, but smooth muscle cells multiply and multiply and multiply. Maybe it's epithelial cells or glandular tissue that multiplies and grows and grows and grows. So you can have different proportions of all three of these types of tissue or one of these types of tissue. But all three of them, if they grow wild and become too numerous, that can cause BPH. So therefore, it's really important to get that biopsy before you start treatment, because there's different treatments aimed at different types of hyperplasia, collagen versus smooth muscle, for example. And we'll look at those the next time. Different treatment options are available. We said that already, for different histological presentations. And all this tissue overgrowth or hypertrophy can crush the prostatic urethra, and you can't pee. You have dysuria. Does BPH morph into cancer? Not very often. That's pretty rare for that to occur. So BPH is benign. What's the look at this epidemiology. 20% of men over 40 have BPH. 75% of men over 60 have BPH. 86 getting toward 90% of men over 80. So it's a really common problem. It's almost like ligamentum flavum hypertrophy. It just gets thick as you age. And its presence, strangely enough, some huge prostates don't always result in dysuria. So some people don't have clinical symptoms. And in fact, 50% of them are asymptomatic. What is the sequelae, though? If it obstructs the prostatic urethra, you're going to have dysuria, trouble urinating. I mean, if it goes on, it can damage the bladder because the detrusor muscle has to muscle up and keep contracting and contracting and contracting. You can wear out your bladder like that. And it could back up all the way into the kidneys. So it's possible. It's rare, but you could get kidney damage from BPH if you let it go too long. What are the causes of BPH? Well, I mean, histologically, the cells in the prostate, whether they be epithelial, glandular cells, smooth muscle cells, fibroblasts, they go crazy and they divide and they divide and they divide. But the other weird thing is apoptosis is broken. So they don't die when they're supposed to, right? Cells are not supposed to live forever. And that's the problem. So they're dividing too fast and they're around too long, and you get a buildup and a massive tissue starts to grow, and it could compress the prostatic urethra. What causes the cell proliferation? Well, we need to talk about DHT, dihydrotestosterone, in order to understand this. So let's talk about DHT. Geek alert, here we go. So it's fun fact. The more testosterone you have in the prostate tissue, the bigger your prostate will grow. That's a fun fact. Testosterone is first produced in the testes, of course, about the 8th week of gestation by the Leydig cells. Some of the testosterone by these testes, most of it is dumped into the inferior vena cava ultimately, but some of it is routed right in to the prostate. There's a back door we're going to look at. And testosterone that gets in the prostate gland can meet up with an enzyme that you need to know this, type 2 5-alpha reductase. Make a card. This is super highly likely. This will be a test question. Make a note card of this. Type 2, not type 1. That's the false answer. Type 2 5-alpha reductase is the type of enzyme that floats around the stroma of all regions of the prostate gland. And it makes DHT. It converts testosterone into dihydrotestosterone, simple as that. And dihydrotestosterone is the one that causes growth of the prostate. There's actually 2 isoforms of 5-alpha reductase, the type 2, which is in the prostate, and then the type 1 5-alpha reductase. Type 2 is in the prostate almost exclusively. Remember, the prostate has glandular tissue, except for the peripheral zone. These secrete prosthetic juices, including PSA, which is not normally secreted into the blood. PSA and everything goes into the seminal fluid, or the prostatic fluid. Fibromuscular stroma supports all these glands and cells. I mean, we could have drawn a fibroblast floating around here. The stroma is just what the stuff sits in. It gives it a little support. All right. Now, what about type 1 5-alpha reductase? That's not made in the prostate. It's made mainly in the liver and in skin cells, especially in sebaceous glands. So this can also convert testosterone into DHT. This is called ester prosthetic DHT, and it's outside of the prostate, so it really has nothing to do with BPH. How does DTH, well, I guess it could get into the prostate though, couldn't it? How does DTH cause prostate growth? The extraprostatic testosterone or the testosterone. No, so let me go back. The extraprostatic BPH, or DHT, dihydrotestosterone, that's not going to cause, like if you have a liver tumor and it's secreting tons of making DHT in the liver, that's not going to cause BPH. But if you have testosterone, like if you're a bodybuilder and you inject testosterone, anytime testosterone from anywhere, anytime that gets into the microcirculation of the prostate, it's going to make DHT because it's going to run into type 2,5-alpha reductase. Okay, so testosterone doesn't matter where it comes. So usually it comes from the testes, but not always. You can have tumors that secrete testosterone, or you can be an athlete and inject this stuff. So let's talk more about DHT, what happens to it. It binds with a receptor, a protein called antigen receptor. Robbins chiropractic board book calls it nuclear antigen receptor. It's the only, not very many people call it that. It's usually just antigen receptor. And the DHT antigen receptor complex is carried into the nucleus of the cell, whether it would be in a fibroblast in the prostate or a collagen or a epithelial cell or a smooth muscle cell. It gets into the nucleus of the cell and it binds to receptors, or it binds to a region of the gene that transcribes through the central dogma certain growth factors. So there's several different growth factor genes that this complex can bind to and stimulate through the central dogma to ultimately make different types of growth factors. And these growth factors do what growth factors do. They make the cell grow and divide faster, and they shut off apoptosis as well. So yeah, with this, a lot of this growth factor, if it's oversecreted, the cells live too long, they multiply too fast, so you get hyperplasia, and it's a big mess. So you should know this. I guarantee you there will be a question on this. So testosterone floating around out, maybe it came from the testes through the back door. Testosterone can float right through the cell membrane. This is let's say it's a smooth muscle cell, but it's in the stroma of the prostate. So now it's floating around in the cytosol. It hooks up with type 2,5-alpha reductase, which does its job and converts it into dihydrotestosterone. Dihydrotestosterone hooks up with antigen receptor, and the two float around. The two are phosphorylated. That's getting a little deep into the weeds, but once they're phosphorylated, they have the energy to go into the nucleus of the cell, and they look for a growth factor gene, and they bind to it, and that stimulates the process of transcription. And then a mRNA is made of the transcript. It goes out of the nucleus, goes to the ribosome, and it's translated into a protein. Specifically, it's translated into a specific growth factor, which is going to cause tissue proliferation in the area. It turns off the apoptosis, so cells stay alive. They proliferate too much. It also raises PSA levels. So play that back, make sure that sinks in. So here's a prostate that was removed in somebody, and you can see normally we'd have a nice big urethra here, and the urethra is so clogged that you could barely put a safety pin in there or a paper clip in there. What about free testosterone? It can get into the nucleus, as we said. It can bind to, I see, free testosterone without converting it. Without converting it over to dihydrotestosterone. It can get into the nucleus. It can bind a little bit to antigen receptor, but its binding affinity is terrible. So it doesn't have a big, it's not the cause of BPH. It's when the testosterone is converted into dihydrotestosterone that you have to worry. We should talk about basal cells because there's another cell type. It's in glandular tissue, but there's epithelial cells in glandular tissue. There's also basal cells, and these basal cells tend to be particularly susceptible to absorbing testosterone and going through that whole central dogma and making growth factors. They can get really grow. Normally the setup in this is a acinar basal cell, or this is just a a regular prosthetic duct here. It's got luminar cells which secrete PSA and other juices to help semen stay alive. Weird situation here. Instead of a basement membrane, there's actually another layer of cells that they sit on. So that's a weird layout, isn't it? And those are called basal cells. And they're really susceptible to testosterone. They can suck in testosterone. And they can go through that central dogma, converts it into DHT, goes in, turns on the growth factor. And normally you look like this, and you can get some of these tumors starting. And there's different, I'm not going to make you know the conformations of these, but you can see the basal cells can get crazy, replicate like crazy. And so if this is going all over in your transitional zone, your prosthetic urethra is going to be crushed. All right, so short lecture, juicy lecture though, 50 slides is not short. So see you guys later. See you tomorrow.